When I introduce advanced care directives or health directives to patients, I explain that as people get older, or if they have some serious illness, they may sometimes consider completing a form that gives them their choices about life-prolonging treatment, if they lose the mental capacity to decide for themselves. An example everyone can understand is if you were to have a big stroke and end up bedridden, doubly incontinent and spoon-fed in a nursing home. Under these circumstances, would they want any treatment to prolong their lives? Directives deal with this issue and many other circumstances where you may have lost mental capacity, such as through a cardiac arrest or severe dementia. This brief explanation is usually sufficient for most people. Directives are about bringing patients and doctors together around a shared understanding of the patient's goals and expectations. It's rarely necessary to involve lawyers in their production. Historically, there are two types of directives. One is to give a preference statement, such as, I would find it unacceptable if I were in a vegetative state. This leaves your doctors to decide what life-prolonging treatments are not to be given to prevent this end. The second is by refusing specific treatments under certain circumstances, such as refusing CPR if you had severe dementia. In my directive, I use a combined approach that reflects the views of most people. They want doctors to interpret what is best to return them to their previous independent life and avoid life-prolonging treatments they are likely to be left severely mentally disabled. But at the same time, patients welcome the opportunity to refuse life-prolonging treatments if the dreaded vegetative state or severe dementia has already arrived. The advantages of directives are that it ensures your wishes with respect to life-prolonging treatments are heard if you become seriously unwell, and it enables you to refuse specific treatments such as life support or CPR. And most importantly, it saves your family from the distress of having to make difficult decisions on your behalf. My directive is only 2 pages long and is divided into sections A to G with 25 numbered questions. Most of the questions you either just answer yes or no to. And the principles that I'm going to discuss in this video are really good for any directive that you might want to complete. There's a brief introduction in the directive, and you should put your name, address, date of birth, and have a witness who will also sign. The witness needs to be a neighbor or a friend, but not a family member or one of your treating doctors. Section A is about getting support from some of your family, a carer or guardian, so that there's always someone to advocate for you in case you become seriously unwell. Make sure you write their names of people you've discussed it with and their signatures in this part of the form. Section B is about writing a preference statement. It should reflect your goals, your values and beliefs. I've given 2 choices of preference statements in 3 and 4. Question 5, you can write your own statement. Particularly people who have cancer or severe emphysema or motor neurone disease, they may have particular issues that they feel they need to attend to. The important issues you may need to consider when writing this is if you were to become severely immobilized, could no longer communicate, you couldn't care for yourself in terms of cleaning yourself or toileting yourself, whether you were no longer continent with your bladder and bowels, could no longer live at home and had to move into a nursing home, and of course whether you retain your dignity. You may also have religious belief which also reflect on these issues. Section C is about your present health if you're admitted to hospital. Now what I mean by this is if, say, tonight you were to have a heart attack and you're admitted to hospital and your heart stopped, would you want CPR, cardiopulmonary resuscitation, or even put on a life support machine? Now many people may say, well, that really depends, doctor, on what the outcome is. Question 6 is whether there's a good outcome. So if the doctors think that your illness is not that severe and the outcome is likely to bring you back to where you were prior to becoming ill, you can say yes or no to that. But question 7 is if the doctors think, say you may have had a severe stroke and the outcome might not be very good, you might want to consider that slightly differently. Now the things to consider when you're writing this section is that if you say no to any of these treatments, you'll almost certainly die. But you must remember that if you say no to any treatments, the focus is usually on palliative care, by which we mean strong analgesia, sedation, and nursing care. Sections D and E are about severe dementia and vegetative states. Because these illnesses normally last several years, and during that time frame other life-shortening illnesses may supervene, such as heart attacks, strokes, cancer, a fractured hip, pneumonia. So it is important to understand that there are many life-prolonging treatments that you consent to or refuse that treat or prevent these illnesses. Section D is on severe dementia. Now by this I mean you will almost certainly be in a nursing home. You wouldn't understand the thread of a conversation. You would no longer understand what a toilet was for or how to shower yourself. Questions 9 to 18 deal with various life-prolonging treatments. Some of the important ones are number 10, refusing antibiotics for life-threatening illnesses. Of course, this excludes minor infections such as urine infections, cellulitis, or other minor problems. Question 11 is also extremely important. Blood pressure, cholesterol tablets, and blood thinners are all extremely important in preventing strokes and heart attacks. If you do not want to live a long time as a severely demented person, you must attend carefully to this question. The next 3 questions are about having operations. Question 14 really deals with if you have refused operations, you can say yes, you'll have an operation after a few days if we're unable to satisfactorily control your pain or distress. Most of these questions are pretty self-explanatory. Just by refusing treatment, that doesn't mean you will die. You may develop some other illness and survive and just be more disabled. However, at this stage in your life, if you had severe dementia or a vegetative state, that might not be that important to you. Section E is about if you were ever in a vegetative-like state. And by this, I mean you were bedridden, you couldn't communicate, you were doubly incontinent, and you had to be spoon or bottle fed. The treatment questions here are very similar to Section D. No refusals in the section on dementia would also apply in this section. The focus where you say no is always, as we've said before, on palliative care. Section F is if you happen to be admitted to a nursing home or hostel or urgent care facility. The simple explanation is that if you had become unwell whilst you were there and you became too confused to make your own decisions, would you want to be transferred to hospital for treatment? Or would you rather just have more low-level care and treatment in a nursing home? Sometimes palliative care cannot always be given in all nursing homes and hostels, so on occasions you may have to be transferred to hospital regardless. Section G is for your GP, family doctor or treating specialist to fill in. And in the same manner that your family members are going to advocate for this form, it's essential to involve one of your doctors. He will check that you filled in the form correctly, that you signed, dated it, and had a witness, and that you understand the consequences of your decision, that where you say no to a treatment, you have understood that you may die. Most doctors might want to review these forms every few years, or if there's a material change in your general condition for the worse. The second part of this video is really for health professionals, but anyone is welcome to watch. How should doctors, hospitals and nursing homes manage someone's completed advanced care directive? A small number of individuals may require special assessment to assess their mental capacity to understand the issues in a directive. I deal with this in greater detail in another video in this series, but essentially, do they understand the consequences of their decision? What do they think might happen if they refuse a treatment? One must use open-ended questions when discussing this, and not closed-ended questions which might have yes or no answers, where obviously people can get 50% of the time people are going to get that right. The second important thing is to check that the patient has made no errors whilst completing the form. A small number say yes to nearly all the questions, and one has to examine the motives for this very carefully. Some of these may say yes to all the questions because in fact they've misunderstood the sense of questions that were written no in error. Some people write yes to all those questions because they have religious beliefs and they do not want to refuse any life-prolonging treatments. Sometimes in the case of extremely frail, elderly and often hard of hearing and partially sighted individuals, their family have completed the form with them and have either not understood the individual's wishes or do not accept their decision not to have life-prolonging treatment. This needs to be gone over carefully with these individuals and sometimes with the family member in attendance. And most people will say no to most life-prolonging treatments except to question 6, which is CPR or life support where there's a good outcome. Question 14, where people often say yes to operations if after a few days they are still in a lot of discomfort, and ditto for question 23. You also need to sign and date the form yourself and make sure that it has been witnessed. Make sure the individual's name is also written on both pages of the ACD. The next thing you need to do is keep the patient's ACD prominently in their notes. So if it's in the nursing home, it should be in the front of their notes, or if you have computer notes, it should be scanned into a computer. Somehow the notes should be annotated on the outside that there is an existence of a directive, and such existence should also be recorded in their past medical history, along with, say, diabetes, stroke, and whatever other issues there are. Occasionally there are problems with disputes between a treating doctor and families about the meaning or veracity of the directive. The way to resolve these is firstly to have a family conference to discuss this, and if that cannot resolve the issue, it's probably a good idea to have a second opinion from another independent doctor about the directive and the patient's situation. Failing this, you should certainly speak to your medical legal team, and in the last and extremely rare resort, you'd refer to the courts. Advanced care directives are an important part of promoting individuals' human rights. They're simple to complete, and indeed my experience is that some 80% of capable nursing home residents and 60% of over 70s in the community will complete them. I hope you've enjoyed this video.